Red Hutch and the University of Washington. We recruited him from UCLA. He trained in the lab of Dr. Owen Whitty, who's really a world leader in immunotherapy, immunology, in a subtype of prostate cancer called neuroendocrine prostate cancer. So John is really interested in the concept of immune therapy in prostate cancer, and he's going to give you an overview today. John?
Thanks, Pete.
Yeah.
Hello, everyone. It's my pleasure to convey my excitement and the field's excitement about immunotherapy for advanced prostate cancer. So I want to first talk about the human immune system, which is actually quite amazing. So the immune system is responsible for a wide range of responses to injuries and diseases on a nearly daily basis. And the immune system can be divided up into two major elements: the immune system, the innate immune system, which provides sort of a non-specific, rapid, and low-potency response, and then the adaptive immune system, which provides a more specific but slower yet highly potent response. And these two systems are really what prevent us from succumbing to a variety of insults, injuries, and pathogens that we encounter pretty frequently. So the innate immune system is composed of a variety of elements, including physical barriers like our skin or mucous membranes. There are a variety of other elements that recruit immune cells to specific sites by producing chemicals that are released into the bloodstream. It's capable of removing foreign substances and then presenting protein fragments on cells to interface with the adaptive immune system. Importantly, I'm going to talk about a concept of education or memory, and the innate immune system has no memory component. But on the other hand, the adaptive immune system does have memory, allowing for future specific responses, and that's something that can be manipulated, and that's something that will be taken advantage of, and we'll talk about that in some immunotherapies that are being developed. The adaptive immune system can be broken up into what's called a humoral element and a cell-mediated element. The humoral element contains B cells, which are responsible for producing antibodies, and then the cell-mediated portion includes T cells, which produce helper cells, and then also cytotoxic cells, which are essentially professional immune killer cells. So there are different cell types within the body that actually make up the innate and adaptive immune systems. So for today's talk, we're really going to concentrate a lot on some of these cells up here, which act as antigen-presenting cells. They can present fragments of proteins to cells in the adaptive immune system, which include T cells and B cells. The organs of the immune system, there are quite a few. There's the bone marrow, which produces most of the immune cells, the thymus, which allows maturation and education of the T cells. There are lymph nodes that provide sort of a biological filter, allowing exchange of substances between tissues and the blood, and also an interface with some of these immune cells. Similarly, the spleen does a similar function with the blood and distributes B and T cells. So essentially what I've done in 3 slides is try to summarize the complexity of the immune system, which is essentially impossible. So I'll give you an example of how this works. So when we're faced with a virus, what can happen is that we have dendritic cells or macrophage cells, and these are part of the innate immune system. And they're capable of engulfing the virus, breaking it down, and presenting pieces of the virus, which are called viral antigens. The viral antigens then are recognized by helper T cells. And the helper T cells actually do quite a few things. So they're able to activate memory helper T cells. So these are sort of cells derived from helper T cells that will stick around in the body for a long time and remember its immune response. It can actually activate B cells to make or differentiate into cells that produce antibodies. And these antibodies can then be used to neutralize the virus itself. Helper T cell can also activate cytotoxic T cells. These are the professional killer cells, and what they do is they can actually recognize as cells that have been infected with virus and then perform sort of the killing of that to clear the infected cells from the body. So what I want to impress on you is that there is a balance that's required in the immune system. And so here I'm showing you sort of this scale where on one end we have immune suppressive signals, and the other end we have immune activating signals. And you can imagine that when there's an imbalance in this system, for instance, if the immune activating signals overwhelm the suppressive signals, then this can lead to things like autoimmune diseases and allergies. On the other side, if you have too many immune suppressive signals and your immune system is not active enough, then you're really going to be prone to infections. And the other thing that one can be prone to is cancer. And so when we think about the development of cancer, the ability to evade the immune system is actually one of the hallmarks of establishing cancer. And people have described various other hallmarks, including being able to grow uncontrollably, resist cell death, and whatnot. But really, one of the most important things that I consider when looking at cancer is its ability to evade immunity. And so how do we enable the immune system to combat prostate cancer and other cancers? Well, what about priming the immune system? We can also consider reducing the immune suppressive signals to sort of tip the balance and activate the immune system further to clear cancer. And then we can also think about the adaptive immune system. Again, the immune system can learn, it can have memory, it can be taught things. And so maybe we can engineer it in a way where we can specifically and potently kill cancer. So I wanted to talk about some of the immunotherapies that are available and being evaluated and clinically investigated in prostate cancer. So prostate cancer is a field that actually adopted one of the first immunotherapies, and that immunotherapy is Ciplicel-T or Provenge, and this is actually a cancer vaccine. And a lot of the clinical work was done by folks across the country, including Dr. Gano here at UW and Fred Hutch. And essentially what Ciplicel-T is it's a cell-based vaccine where you take cells from the patient and you manipulate them to express an antigen. And this antigen is PAP. And you can grow these cells outside of the body, and then they're reintroduced back to the patient. And essentially what happens is that the patient has now the ability to present this PAP to the adaptive immune system. And so the adaptive immune system is sort of activated to respond now to this cancer antigen. And so the idea is that the re-educated immune system can now attack some of these prostate tumor cells based on the expression of PAP. So this was actually FDA approved in April of 2010, and it did in fact show a 4.1 months survival benefit. And you can see the curves here where they split when you compare patients that were treated with Ciplicel-T versus a placebo. So given that, folks have been excited about other types of vaccine therapies. So they've thought about other antigens that could be potentially presented to the adaptive immune system. And one such strategy is to use, for instance, PSA. Right? We know that PSA is expressed on the majority of prostate cancers and can be used to monitor the disease. And so folks have used viral systems to introduce the expression of PSA and then combine this into a vaccine that could be introduced to patients. So last year, actually, there was a study called the Prospect trial, and unfortunately, in metastatic castration-resistant prostate cancer, the vaccine wasn't found to be effective. But this doesn't mean that, prostate cancer vaccines are going to be ineffective overall. I mean, we have evidence from Ciplicel-T. So the question is, how can we make them more effective? Well, the other idea is to consider combining these vaccines with other immune modulating agents to allow the immune system to improve its response and really take the brakes off its response to these agents. And so that's what I'm going to talk about now, and this is an area of great excitement in the field of oncology overall. And I'm going to talk about a class of agents called immune checkpoint inhibitors. And this is a nice diagram here. So in a normal anti-tumor response, you have a T cell that can engage a tumor based on the expression of specific tumor antigens. And what happens is that the tumor can actually express proteins on the surface that put the brakes on this to tell the T cell, don't be active and don't kill me, okay? And these are proteins called PD-L1 and PD-L2, and there's a variety of other proteins similar to this. And so the idea is to actually block the interaction of PD-L1 or PD-L2 with its receptor on the T cell. And so if you do that, you're actually taking the brakes off, right? And now the T cell is now able to sort of reactivate and engage the tumor and kill it. And so this has actually been approved in a variety of cancer. I'll show you on the next slide. But specific to solid tumors, this is the first treatment that's actually been approved not based on the type of tumor, but based on the genetic abnormality that's present on the tumor. And so prostate cancer patients and other cancer patients who have microsatellite instability, or it's called a mismatch repair deficiency, can actually get this treatment as long as they don't have any other treatment options. And so why does this work in patients that have DNA mismatch repair? Well, folks with DNA mismatch repair actually develop quite a few mutations. And so when they develop mutations, the proteins or the antigens that are presented by the tumor are now different. And so they can develop what's called these neoantigens. And because they produce a lot of neoantigens, now the T cells no longer can recognize these antigens as being endogenous or self-antigens. They're now seen as foreign, okay? And because they're thought of as being foreign, this will elicit an immune response. And if you take off the brakes on that immune response, potentially that could aid in the killing of these tumor cells. So this was FDA approved in May 2017, again, for any solid tumor with DNA mismatch repair abnormalities based on 5 studies. And importantly, they took 149 patients with 15 different cancer types in total. And the overall response rate was about 40%, which is pretty impressive. So in prostate cancer, the next logical question is, what's the rate of DNA mismatch repair? Well, a lot of work that's been done here and elsewhere has shown that in advanced prostate cancer, the rate of DNA mismatch repair is about 3 to 12%. But work by Dr. Schweitzer here, who just gave a presentation, has shown that there may be some subsets of prostate cancer, including ductal adenocarcinomas of prostate, that have increased frequencies of DNA mismatch repair up to 40%. And so this may be an option for these sorts of patients. And again, to show that this is really revolutionizing cancer, it's been FDA approved for so many other solid tumor indications. The issue with these sorts of agents is that this is sort of non-specific, right? You're essentially reducing the immune suppressive signals, activating in a non-specific manner the immune activating signals. So not surprisingly, what we are encountering are these new sets of immune-mediated side effects that can attack organs like the lung, the colon, the liver, endocrine glands, kidneys, and rarely people are even describing other organs in the body. When we think about these sorts of agents for genetically unselected metastatic prostate cancer patients, so how about other patients that don't have this mismatch repair, the 97% to 80% that don't have that abnormality? Is it active? Well, initial studies suggested that no, it's not active. But then Julie Graf at OHSU actually has been engaged in a clinical study where she's taken 10 patients with metastatic castration-resistant prostate cancer who progressed on enzalutamide and treated them with pembrolizumab in addition to enzalutamide. And what she's described is that actually 3 out of 10 patients had substantial PSA reductions, and 2 out of 3 had a partial response. And the important thing to note here is that when you look at MSI or the mismatch repair status, there was one patient where they did have DNA mismatch repair, but one of the other patients that were evaluated, it was absent, right? So this suggests that there may be some activity in some patients without DNA mismatch repair deficits. And additional trials are really evaluating combinations with other agents, either rationally or with cytotoxic agents, to determine whether you can enhance that activity. So this is something that the adoptive T-cell therapy is something that I'm personally interested in, and something that I'm working on in the lab on. And this is sort of a very exciting field that's been spearheaded and has been in the media quite frequently. So I want to describe what adoptive T-cell therapy is. So you take the patient, you can actually pull out immune cell subsets by leukapheresis, and then you can actually grow out T cells, and you can actually manipulate them in a dish. And so one idea is to manipulate these T cells to re-educate them, or to introduce receptors that enhance their specificity or even enhance their potency, expand them in the dish, and then put them back into the patient and allow them to work and kill cancer. And so essentially what you're doing, you're programming soldiers from the immune system that you put back, and they develop an army, and you put them back into the patient, and they wage war on cancer. And how does this work? Well, in the case of chimeric antigen receptors, you can actually engineer these things so that there's a recognition domain, so that you can actually recognize a specific aspect of the tumor cell. And then you engineer the portions inside of the T cell so that you elicit a T cell response. So in the case of the professional killer cells, this is the portion, right, when stimulated by the recognition domain that activates these T cells to start killing, okay? So the power of this has been called utterly transformative by the New York Times. And this has been transformative in ALLs and some B-cell malignancies where you're seeing complete response rates up to 90%. And you know, what's expected with chemotherapy would be something like 30%. So you're talking about a threefold increase in the complete response rates. And you know, this is actively being investigated in other types of cancers. For instance, this is a PET scan of a patient with multiple myeloma. All of these black dots that you're seeing scattered across the body are actually foci of tumor. And so this is before treatment, and this is after a CAR treatment targeted at a multiple myeloma antigen called BCMA. And you can see that it's cleared quite a lot of that cancer. And so this is what we want to harness for prostate cancer. And so what does this require? Well, we need to find target antigens that are prostate or prostate cancer specific. And the other thing is it can't be expressed at high levels in normal tissues, or else you know, these re-engineered T cells will attack the normal tissues. Well, some folks at the City of Hope and UPenn have already developed some of these CAR technologies, and they're targeting, for instance, PSCA, which is prostate stem cell antigen, and PSMA, which is prostate-specific membrane antigen. And actually, the PSMA trial is actually open at UPenn currently, and will soon open at City of Hope shortly. So what are we doing here at the City of Hope related to CAR T? One of my interests is actually identifying some of these targets in aggressive variants of prostate cancer. And so we've used a lot of bioinformatic techniques to identify some of these antigens that are expressed in subtypes of cancer. And this is to just show you that we have, for instance, discovered the expression of one antigen called CEACAM5 in the aggressive neuroendocrine variant. This is immunohistochemistry where brown represents expression of CEACAM5. And it seems to be pretty exclusive to neuroendocrine prostate cancer and not prostate adenocarcinomas. And when we look at a patient tissue slide where there's prostate adenocarcinoma on one side and neuroendocrine prostate cancer on the other, we see that the expression seems to be pretty specific for neuroendocrine prostate cancer. Well, we've taken this a step further, and this is just a video where we've mixed re-engineered CAR T cells targeting CEACAM5 with cell lines that either express or don't express CEACAM5. And so on the left, you see that the green cells, the target cells, continue to grow just fine. But on the right, the red CAR T cells are essentially engulfing and destroying all of the neuroendocrine prostate cancer cells that express CEACAM5. So this really demonstrates sort of the specificity and also the potency of this technology in the context of sort of a culture dish-based experiment. So this is something that we're very excited about. So to summarize, immunotherapies are revolutionizing cancer treatment. Modulation of the immune system can really tip the balance to fight off cancer, but we have to be mindful of some of the toxicities that can arise from this. Subsets of prostate cancer can be more sensitive to immunotherapy with checkpoint inhibitors, and you know, T cells that are engineered to seek and kill, these are really going to be exciting and hopefully will develop over the next several years. And Fred Hutch and UW investigators are actively investigating all aspects of immune-based strategies for prostate cancer. Thank you.
Okay.